Alaikum, welcome to the program. This is the mid-morning talk show with me, Julie Ali. It's just gone 11 o'clock and a lot's coming your way. Let's kick off right away with our first guest who has been standing by for a couple of minutes. And we're going to be talking about new hope in HIV prevention and the World Health Organization guidelines with Dr. Tom Ellman. He's with Doctors Without Borders and, of course, the director of the Southern Africa Medical Unit. Dr. Tom Ellman, a very good morning to you. Welcome to the program.
Morning. Thanks for having me.
Okay, so apparently there is this new drug that the World Health Organization indicates that this really is a significant moment for global HIV efforts. What exactly is this drug? Is it only available in South Africa? And why has it come about at this, at this point in our lives?
So the drug that was causing all of the buzz recently, and we've just had WHO come out with very fast guidelines, is called Lenacapavir, and it's basically an injectable antiretroviral for HIV. And what's exciting about it is that whereas to prevent HIV, people we've had PrEP, as it's called, preventive treatment for HIV, which has been a daily pill that people have had to take, people at higher risk of HIV for a long time. We haven't had anything that you can kind of take and forget about. And the amazing thing with these injectables is that they last for 6 months. Wow. It means that somebody taking an injection just twice a year could be close to 100% effectively prevented from getting HIV. Of course, it doesn't prevent sexually transmitted infections and pregnancy, so people still need to use condoms and take other measures. But to have something that effective in preventing HIV is a real breakthrough. And it comes at the same time, it gives hope for HIV and for changing the epidemic and eventually eliminating it at the same time as we're seeing these catastrophic cuts in support to HIV, particularly from the US government, but also from other big donors and European governments. So it's a really critical time, and it's really important that people know about these opportunities as well as the threats to the ongoing fight against HIV.
Well, you just preempted my second question regarding the US aid cuts. How does that impact on your work? And then who would fund this new medication? I'm kind of wondering, we're talking cuts on the one hand, and we're very positively promoting a new injectable, which obviously from your response indicates that it's really a good news story.
Yeah, so there's a lot to unpack in that question. First of all, our organization, Doctors Without Borders, Médecins Sans Frontières, we don't take any government funding from the US government or from European governments. And a large part of it is to protect our programs against these kind of sudden, crazy political decisions that undermine health globally. We depend on private donors, small-scale private donors. And that means that we are, to some extent, independent, and we can carry on, and we are providing injectable. There's a shorter-acting injectable prevention that's already on the market and very hard to access, called cabotegravir, that we are using, which is an injection every 2 months, which we're starting to work with in Zimbabwe, in Mozambique, Malawi, a few countries. But the main impact that the cuts are having on our work and on the HIV fight in general is there are reduced opportunities. So more people are desperate for support, and MSF as an organization cannot replace what's being taken away and what's being lost. So there is still a huge fight to do around this. Another element of this to say is that, yes, these things are very expensive. Currently, this prevention tool, Lenacapavir, in America costs $30,000 a year, which
Phew.
is completely unaffordable.
Mm.
Currently, the alternative that's used in South Africa, oral prevention taken daily, is down to around $40, $50 a year. And we really need the price of this drug to come down. You'll remember about 20 years ago, there was a big fight to reduce the price of antiretrovirals for treating HIV, which similarly were over $10,000 a year in the countries where they were being produced in the West. And now those same drugs are available for around $50 a year in sub-Saharan Africa. And exactly the same thing is possible if we can fight for reducing the price. And part of that fight is to get more demand, to get people requesting. I'll just quickly respond to your other point about what needs to happen. So we need to push back against these cuts. We need to convince the American, European governments, the big international donors, that this is a very short-sighted, wrong-headed decision to reduce the financing, not just of HIV, but of global health and humanitarian intervention in general. It's protecting everyone, including people in America and Europe. But at the same time, it's also clear that African governments and other donors need to step in. It isn't, this is just it's a wake-up call that Africa cannot rely on donors in the US. But it's also true that there is no way, with this sudden catastrophic drop in funding, that governments in poorer countries can step in and fill the gap. So right now we need all hands, we need everything. Governments to step in the domestic resources. We need shifts around the global financing of healthcare, including pushing against debt repayments, which still from poor countries are higher than the amount received in aid. And we need to convince the rich countries that they need to step up and continue to fund the fight against HIV.
We've not heard about HIV and AIDS in a very long time, and we do know that this discussion has been going on for a very long time, but it seems to have gone under the radar for a while now. And people could very easily mistake the fact that HIV and AIDS is not being spoken about because the battle against that condition or disease has been won, so to speak. But it's still a huge battle, is it not? And with all of the awareness campaigns over the years for a long, long time, one should have imagined that by now the public is well aware of risky sex behavior and however else you contract HIV and AIDS, that by now we would have been on top of this, and you and I wouldn't be sitting here discussing a new injectable that is that much easier to use and protect yourself against this disease.
Yeah, I mean, there is a real risk of complacency. AIDS has not gone away. It never went away. We don't have a cure for HIV. We don't have a vaccine for HIV, and we need them. What has changed is that people are no longer, at least not in Southern Africa, in South Africa, losing their friends and relatives every day, every week. Funerals coming continuously, which was the hallmark of HIV in the 90s and early 2000s, are no longer so visible thanks to the efficacy of antiretroviral treatment and the roll-up, the very slow rollout of treatment. But now what this means is that around 30 million people globally and many millions in South Africa depend on these pills and depend on taking them every day to stay healthy. If the pills disappear, we go back to the bad days at the beginning of the epidemic. And that is unfortunately a real possibility. So the funding needs to continue, the drugs need to continue, and people cannot be complacent about that. But we also need to roll out these medications that make it much easier to treat HIV, and particularly right now, the injectable antiretrovirals, which, as I said, we are mostly looking at using them to prevent HIV, but potentially they can also treat HIV and make treatment simpler. And some people may well prefer to have an injection every few months than have to take treatment every day. That's not yet being pushed widely in Southern Africa. But again, as the prices come down, it's definitely a hope for the future, as long as funding continues. And maybe the other thing, as you said, the stigma of HIV and the stigma related to sexual risk behaviors also haven't gone away. Those are incredibly hard things to shift in societies. And that also needs to continue. If we can't talk about safe sex, if we can't talk about risks, if we can't talk about the risks faced by men who have sex with men, gay men, then we are keeping ignorance and silence, and we're reducing the chances that people can find out how to protect themselves or come forward to access prevention and treatment when they need it.
And sadly, that's one of the barriers. People know that they'd be marginalized, and there is still the stigma. So I think that also lots more awareness needs to happen for people to realize it's about their own health and well-being, and they need to go out and they need to get the necessary treatment. So you have indicated, Dr. Ellman, that we have seen a shift, a positive shift regarding the treatment and regarding antiretrovirals, HIV, AIDS, etc., etc. We're seeing a positive shift, a change in our population here in South Africa. But what populations or regions could benefit from this long-acting injectable? And will it be readily available in those countries? I'm thinking of other countries, other third world countries for that matter. So I suppose that too comes with a risk, does it not? Or
Yeah,
difficulties?
absolutely. So right now, this is not available for the majority of South Africans either. And it is needed in South Africa, and it will need funding in South Africa. And South Africa is one of the countries that has the most well-functioning health system in Africa and the highest coverage, amongst the highest coverage of treatment prevention and treatment, of HIV prevention and HIV treatment support. There are other countries, many of which are the focus of the work of my organization, Doctors Without Borders, like Democratic Republic of Congo, Central African Republic, Burundi, much of West Africa, where coverage is much lower. And if you have HIV, you're going to find it much harder to access treatment. And if you're at high risk, you're going to find it much harder to access prevention. So South Africa is key to this, as it was to antiretroviral treatment, because there are so many people at risk and so much needs in this region. But other countries where there are where people have a greater struggle accessing healthcare are in danger of having to wait far too long to access these medications. The other barrier alongside stigma is that many of the highest risk populations, the people at greatest risk, for example, sex workers and their clients, and LGBT community, and particularly MSM and transgender, live in countries where conservative legal systems criminalize their behaviors and criminalize them and their access to healthcare, and also where cultural attitudes make it very hard for people to feel safe going to government health services. So there's a huge amount of work to do in addressing that. And unfortunately, what we've seen with the cuts from PEPFAR in particular, and the USAID, the American government cuts, is that they have specifically targeted those populations at greatest risk. So, for example, they agreed to continue funding prevention of HIV for pregnant women, but they took away all support to the highest risk populations, to programs working with sex workers and LGBT communities.
Okay, we're going to go for a quick ad break. When we come back, we have just one or two more questions for you before we let you go. So please do stay with us.
Are your financial goals feeling out of reach? Yassin Badat Financial Advisory is here to turn your aspirations into achievements. Our dedicated team, armed with a history of success, is ready to guide you through the complex nature of financial and investment planning. Whether you're a seasoned investor or new to the game, our personalized solutions cater to your unique goals and risk appetite. Trust in our commitment to transparency, integrity, and excellence. Ready to unlock a world of financial freedom? Partner with us today. Call Yasin Badat Financial Advisory at +27333462071 or visit www.yasinbadat.com. Yasin Badat Financial Advisory, guiding you to financial success.
They say breakfast is the most important meal of the day, yet many children go to school hungry because of poverty. Penny Appeal South Africa's Breakfast Club aims to get a warm, hearty meal to underprivileged children so they can spend their day prospering in their schoolwork. Help feed a needy learner for only 5 Rand a day or 150 Rand a month. Or visit our website www.pennyappeal.org.za or call 031 1100 573 to find out how you can donate. Penny Appeal South Africa. Small change, big difference. When the perfect blend of stylish decor, exquisite halal cuisine, and warm hospitality come together, it could only mean Albeit Lodge, your true home away from home. Albeit is the ideal heaven for families, business people, and tourists with its 4-star family rooms and other luxurious facilities, conveniently situated close to Port Elizabeth Airport, the beach, and other amenities. Your stay will be truly unforgettable, as you'll be taking home lasting memories of the warm hospitality, the serenity and tranquility that Albeit has to offer. For reservations, call 041 583 6415 or visit www.albeitlodge.co.za.
Abu Huraira narrated that he heard the Prophet Muhammad, may the peace and blessings of Allah be upon him, say, "In black seed there is a healing for every disease except death." Experience the health benefits of this ancient blessed seed by using the Tib Black Seed range. Black seed assists the body to boost immunity, regulate blood sugar levels, reduce inflammation, and act as a potent antioxidant. Experience a holistic approach to health by introducing the Tib Black Seed range into your routine. Available in capsules, pure cold-pressed oil, and a vapor rub. Trust Tib Health Sciences for quality black seed products. For more information, visit blackseed.co.za. Available at leading pharmacies.
Hey Gulam.
Yeah?
Did I return your lawnmower last month?
No, bhai, you didn't.
Oh no. Now what'll I do? I wanted to borrow it again, man.
With Randry Jewelers, you won't have to borrow or lend because the prices are so well trimmed on all gold and diamond jewelry. Alternatively, we could remake your old jewelry into a brilliant new design. Visit Randry Jewelers at 151 Stevens Lamini Road, Musgrave, Durban. Randry Jewelers, the family name you can trust.
Rejuvenating media day by day. This is Salam Media.
Welcome back. We are talking with Dr. Tom Ellman. He's with Doctors Without Borders. He's in fact the director of the Southern Africa Medical Unit, and we are talking about new hope in HIV prevention. It is about the new injectable that is now available, but he has talked about all of the potential challenges regarding access to this new injectable. So let's start by asking Dr. Ellman, what message does MSF have for pharmaceuticals holding the patents on this new injectable regarding access to the global south?
Well, when you said there's this new injectable that is now available, that's the point. It's only available if you are in a rich country or if you are very wealthy. And the point is that this drug is currently well over the odds in terms of pricing because pharmaceutical companies are trying to make as much profit as they can. So in America, as I said earlier, this drug costs $30,000 per year per person. Sure. And it should, there have been studies that we've also been supporting that have shown that even with a profit of 30%, the drug could come down to around $40 to $50 per year. That's the price at which it becomes really affordable. And as every minute we waste in pushing the price down, more and more people are becoming infected with HIV. So what we are asking the pharmaceutical companies to do is to accept a reasonable profit, not these ridiculous, these companies are amongst the wealthiest and most profitable in the world. And they make that profit on the back of rich countries to the denial of poor people, meaning that the drugs are not available where they're most needed. And there's no question they are most needed by the most vulnerable people in sub-Saharan Africa and in Southern Africa. So on the one hand, we're calling for these companies to realize and to respect that and to make the drug as accessible as possible, with some success, but limited success in pushing that, because the bottom line for these originator drug companies and all drug companies is profit. The way around that is to ensure that there is as much competition as possible, as soon as possible, by bringing in generic competitors. And there are various ways that that can be done. And we have been trying to push the company, Gilead, that makes Lenacapavir, to allow as many and as much opportunity for generic manufacturers to come into the market to help make the drug more available. Right now, there is a voluntary license that the company have put forward, which in principle allows more access, but there are a number of flaws to it. It's only available to 6 generic companies rather than any company that is interested. That's available only if they supply a limited number of countries. It's quite a large number. It includes most of the most at-risk countries, but it excludes many middle-income countries where people will equally need access and won't have it. They're also refusing to tell us how much the drug will cost, meaning that for governments and other actors wanting to buy it, it's very difficult to plan and to budget and to work out what you need. And the current plan is to scale up access over the next 3 years to around 2 million people. That's what the Global Fund has discussed. We're talking about the needs for far more than that. And indeed, UNAIDS, there was a target which should have been achieved by this year, 2025, of 21 million people on PrEP. So even the ambitions, which some are saying are great, 2 million, it's certainly better than nothing, is far, far below what's actually needed. So there's a huge amount of push to do, both to ensure that the pharmaceutical companies respect the public health needs and don't block access, and at the other hand, that governments and in some cases the law courts, with support from civil society, push in to force companies to make the drug more available by opposing patents that shouldn't be granted in countries, by pushing for registration in countries where the company have not been interested in registering it, and perhaps potentially by doing compulsory licenses where a generic manufacturer is enabled to produce the drug without the agreement of the company that's made it. So there's a range of things, and all of these need to be acted on.
And normally when a new drug is introduced on the market, pharmaceutical companies do argue that they've spent years and loads of finances in developing that drug. So what is the period that patent stays in place before it can go onto the generic markets? And I'm sure the injectable that we're talking about right now has passed that date. Would it be about 3 to 5 years?
I'm going to have to check that. I'm afraid I can't remember the exact date,
Okay.
but typically a patent will be 10 to 20 years. And in addition, often there will be multiple patents applied to a product. So it may not just be the product itself that's patented. It may be some of the tools that are needed alongside it. And as it approaches the end of its patent, minor changes are often made to evergreen the patent, to make it last longer and longer. So there's a whole range of ways in which patents can be extended. But even when the patent expires, there is still the need for generic manufacturers to come in. So for the foreseeable future, this drug will be patented in South Africa, and we're going to need to find ways either to work with or around the patent. And in addition, as you say, yes, companies put a lot of money into researching drugs, but the profits that they recoup are far, far greater than the amount that they put in. And that's where these calculations come from. A reasonable profit, 30% profit applied, would allow this drug to be sold at around $50 or less per year.
So it's really about the bottom line, is it not? And not necessarily about people's health and well-being and healthy nations. But I do know you've got a time constraint, so let me put my final question to you.
I'll just quickly jumped across to check. So the patents on lenacapavir will start expiring in 2034, and it could extend that monopoly even longer beyond 2037. So it's a long period that we are going to still have to work with or around the patent on lenacapavir.
Okay, so let's wrap up. I've really enjoyed chatting to you, and I'm an ordinary layperson. I don't know much about pharmaceuticals and medicine, but you made it so very understandable. So thank you very much. But finally, looking forward as MSF, what further policy or scientific developments do you hope to see in response to the global HIV situation?
Well, I mean, I think there's two really big things that we need. One is the ongoing engagement of communities. As you mentioned, this kind of idea that HIV has gone away is a real threat to ending the epidemic. People need to be aware it hasn't gone away. People need to understand and be aware of what is available, like this injectable preventive drug, lenacapavir, and they need to fight for it. So those alliances with civil society are really, really important. At the other end, we need government and donors, South African government amongst many others, to continue to invest in research, because we are close. We're close to developing vaccines against HIV. We're close to developing long-lasting treatments like lenacapavir, which will make it much, much easier for people to stay on medication. So the research really has to continue, and it's only going to continue if people and communities understand the threat, stay involved, and keep asking and demanding that investment is made into these tools, and that when they are found, they're made available to people. So yeah, I'm hopeful, but I think that what we really have to have is communities who are aware, and that's why it's great that you're having this discussion, because awareness and engagement of community are going to be key to health in the future.
Dr. Tom Ellman, thank you indeed for talking to us. We salute you and your organization, Doctors Without Borders. We do know the type of work you do in the most dangerous of situations. Dangers, when I say danger, wars and, of course, diseases, etc., etc. So we do salute everyone at MSF. Keep up the good work, and thank you for being with us. God bless.
Thank you.
It is exactly 11:33. We are moving along, and our next interview will be with Mike Bolhuis. He, of course, is a specialist investigator, and we're going to be talking about proof of payment scams.